Imagine the MV Hondius, a Dutch-flagged cruise ship cutting through the Atlantic in May 2026. It is an unremarkable voyage until the medical bay becomes a floating quarantine. What began as sea legs and minor fevers among passengers quickly spirals into a nightmare of frothy pink sputum and sudden respiratory crashes. This was not a standard outbreak. It was Hantavirus Pulmonary Syndrome, a disease that turns a previously healthy person into a catastrophic cardiopulmonary failure in a matter of hours. As the ship was refused docking rights by Cape Verde, the medical team was forced into a geographic tragedy, performing high-stakes resuscitation in a low-resource gray zone. At the time of this posting, a global Andes virus outbreak linked to maritime travel has resulted in 11 total cases and 3 fatalities, representing a case fatality ratio of roughly 27%. In a coordinated containment effort, more than 120 former passengers have been repatriated via non-commercial transport to undergo a 42 to 45-day quarantine across 12 countries, while 27 crew members remain completely isolated aboard the MV Hondius as it sails toward Rotterdam for disinfection. Within the United States, the CDC is actively tracking 41 Americans. The highest risk individuals are in specialized facilities at University of Nebraska Medical Center and Emory University Hospital. For clinicians and educators, the MV Hondius is more than a tragedy. It is a masterclass in clinical volatility. Hantavirus Pulmonary Syndrome represents the perfect storm for medical failure. Low frequency, high lethality, and a deceptive presentation. This guide serves as a strategic blueprint for medical educators to move beyond simple task training and into the realm of intelligence-led, high-fidelity clinical simulation. To simulate Hantavirus Pulmonary Syndrome effectively, we must first understand the biological deception that makes it so deadly. In the high-pressure ecosystem of emergency medicine, clinicians are often prepared for the expected. However, hantavirus represents a unique challenge where a vague, flu-like prodromal phase lures the clinician into a false sense of security, followed by an explosive cardiopulmonary collapse. The 35% fatality rate reported by the World Health Organization leaves zero margin for diagnostic delay. Because the disease is rare, the muscle memory required for its management is often absent. Simulation provides the only safe environment where we can engineer this perfect storm, allowing teams to experience the visceral shock of the hantavirus pivot without risking patient lives. The diagnostic challenge is rooted in biological deception. During the prodromal phase, the virus is quietly attacking the vascular endothelium, yet the patient presents with a benign clinical profile. By the time the cardiopulmonary phase begins, the patient is often already in a state of irreversible shock. Standard resuscitation protocols for sepsis often involve aggressive fluid boluses. In hantavirus, where the primary pathology is a systemic plasma leak rather than pump failure, these fluids do not stay in the vessels. Instead, they migrate immediately into the lungs, accelerating the patient's respiratory arrest. To survive, a patient needs a clinician who recognizes the environmental and laboratory signals before the first fluid bolus is ordered. The hallmark of the syndrome is capillary leak syndrome. Unlike cardiogenic pulmonary edema where the heart fails to pump, or traditional ARDS where inflammation damages the alveoli, hantavirus is characterized by a non-cardiogenic, non-inflammatory increase in vascular permeability. The virus invades the endothelial cells and triggers a systemic leak. If you think of the vascular system as a network of pipes, in heart failure, the pump is broken and fluid backs up. In hantavirus, the pipes themselves become porous. Protein-rich plasma escapes the vessels and floods the interstitial and alveolar spaces of the lungs. This explains 2 critical clinical findings: hypovolemic shock and hemoconcentration. As plasma leaves the blood vessels, the blood volume drops, leading to profound hypotension. Because only the fluid escapes while the red blood cells remain, the hematocrit rises sharply. This is why fluid resuscitation is so dangerous. Adding more fluid to a leaky pipe only ensures that more fluid ends up in the lungs, effectively drowning the patient from the inside out. The clinician must rely on the Hantavirus diagnostic triad, which serves as a biological fingerprint. This triad includes thrombocytopenia, typically with a platelet count below 100,000, which reflects direct viral impact on platelets or consumption due to intense endothelial activation. The second marker is hemoconcentration, often with a hematocrit greater than 55%, which is the gold standard sign of plasma leak as the blood becomes sludgy. The third marker is a white blood cell count shift to the left with immunoblasts, representing an intense, atypical immune response. The synthesis of these three markers, combined with a history of rodent exposure or regional rainfall patterns, is the critical realization the simulation must provoke. The architecture of a rare disease simulation must follow a scaffolding model. We do not simply drop learners into a respiratory crash, we build the tension to match the biological reality of the disease. By mirroring the two-phase progression, we can evaluate diagnostic inquiry and crisis resuscitation. The pedagogical goal is to test resilient recognition, the ability to maintain clinical clarity as the environment becomes increasingly chaotic. The simulation should be designed as a 20-minute experience, with the first 10 minutes focused on the diagnostic phase and the final 10 minutes on the resuscitation crash. The patient notes their muscles ache and they just feel really unwell. Vital signs show a heart rate of 105 and a blood pressure of 115/75, with oxygen saturation at 94%. In this phase, learners must ask about environmental and travel history. If they mention rodent exposure, the facilitator provides information about the 2026 rodent mast year. Again, the patient notes their chest feels tight and they are getting short of breath. As the scenario moves into the lab reveal, the patient reports chest tightness and oxygen saturation drops to 91%. At this point, the team is handed the lab triad report showing low platelets, high hematocrit, and a high white cell count with 15% bands. The pivot occurs around the 8-minute mark. Oxygen saturation drops to 85% on a non-rebreather mask, while the heart rate rises to 130 and blood pressure drops to 90/50. This is when the technical team activates the frothy pink sputum pump and the patient begins agonal gasping. In the resuscitation phase, the patient experiences a tachybrady arrhythmia, where the heart rate cycles between 140 and 40 beats per minute. If the team gives more than 500 milliliters of fluid, the blood pressure stays low but oxygen saturation drops further, forcing a rapid sequence intubation. In the final stabilization phase, the team must titrate norepinephrine and negotiate a transfer for advanced ICU facilities, or ECMO. To ensure the simulation is intelligent, we program the Manikin with specific logic. For example, we use a fluid punishment logic where any intravenous fluid bolus over 500 milliliters results in coarse rails and a 10% drop in oxygen saturation. This teaches learners that aggressive fluid is iatrogenic in the setting of a plasma leak. We also implement a PPE trigger where any intubation initiated without an N95 mask or powered air purifying respirator results in a scenario failure. This enforces the 2026 guidelines regarding aerosol-generating procedures for unknown respiratory viruses. Red herrings, such as a nurse mentioning a recent trip to a region with Nipah virus, to see if the team stays focused on the laboratory markers of hantavirus, should be avoided. Trust and psychological safety are as critical as the technical engineering is vital for the suspension of disbelief. The success of a crash scenario depends on the team feeling the stress of the physical symptoms. We use automated deterioration profiles to minimize manual overrides. The hemodynamic slide line links blood pressure to the fluid infusion counter, while the tachybrady loop forces the team to switch between preparing for cardioversion and preparing for pacing. We also set the Manikin's physical chest rise to a high respiratory rate of 38 to 42 breaths per minute, which is a vital visual cue for triggering the decision to intubate. Moulage techniques must be sensory first to replicate unique clinical signs. For the frothy pink sputum, we use a mixture of distilled water, strawberry-scented soap, cornstarch for viscosity, and red food coloring. This mixture is loaded into the Manikin's internal secretions reservoir and set to pump out at the 10-minute mark. This forces the learners to manage high-volume suctioning and wet airway protocols. We also use deep blue pigments on the nail beds to simulate distal cyanosis and a high-viscosity synthetic blood for lab draws. When the learner tries to draw blood, the syringe feels heavy or difficult to pull, reflecting the high hematocrit seen in real patients. Beyond individual training, the simulation serves as a systems-level quality improvement tool. When we run an hantavirus scenario, we are conducting an in-situ audit of the facility's ability to respond to a high-consequence pathogen. We apply lean principles to identify waste, such as the distance to PPE carts or the time it takes to mobilize an ECMO team. In the 2026 outbreaks, several medical staff were infected during intubation because they defaulted to standard surgical masks during the chaos of the crash. The simulation allows us to test if the team will pause for the 45 seconds required to properly don protection, even when a patient is deteriorating. A simulation is a living document that must be updated based on global events. Following the MV Hondius tragedy, simulation scripts globally were updated to include maritime travel in the screening criteria. We also integrate regional risk mapping based on climate data. If the simulation is set in a rodent-massed year triggered by El Niño rainfall, the cues should be subtler to test if the team is maintaining a high alert suspicion. This transition to intelligence-led simulation is no longer a luxury but a necessity dictated by a volatile planet.
Debriefing these high-stakes scenarios requires a move away from shaming and toward inquiry.
Because hantavirus simulations often end in the death of the Manikin given the high fatality rate, we must manage potential moral injury.
The facilitator uses advocacy-inquiry strategies, noticing specific actions like a delay in suctioning and asking what the team was seeing at that moment.
We explore why a team might have defaulted to sepsis protocols despite the laboratory evidence of a plasma leak.
We also ask the respiratory therapists and nurses to share their cognitive load, evaluating if the team hierarchy allowed important observations to be voiced.
The 2026 outbreaks were predictable for those who understood climate signals. Extreme rainfall across the Americas and southern Africa led to rodent-massed years, causing a tenfold increase in rodent populations. Clinicians must be trained to ask about regional rainfall patterns as part of a standard respiratory workup. Medical education now requires a One Health perspective, which recognizes that human, animal, and environmental health are interconnected. When a doctor looks at a patient with a fever, they should be thinking about the climate events of 6 months ago as much as the heart rate on the monitor. The MV Hondius case also introduced the variable of diplomatic friction and ethical gray zones. We can create sub-scenarios where the team is informed that no hospital within a 500-mile radius will accept the patient due to quarantine fears. This forces the team to manage ECMO-level respiratory failure in a standard emergency room bay for an extended period. Clinicians often feel deep distress when they possess the skills but are denied the equipment due to international fear. Debriefing these scenarios focuses on resilient resourcefulness and how to provide the highest possible care when the broader system creates barriers. The MV Hondius effect will be remembered as the moment the medical community realized that rare does not mean irrelevant. We are moving toward a future where a clinician's differential diagnosis list is informed by satellite rainfall data and AI-driven triage tools. As medical educators and simulation strategists, your role is now one of strategic defense. You are the engineers of the muscle memory that will save lives in the next outbreak. Every time you meticulously mix the frothy pink sputum or program the tacky Brady loop, you are preparing a team to face the perfect storm and win. Proceed with precision, engineer with realism, and debrief with empathy. The next crisis is already on the horizon, and it is our responsibility to ensure our teams are ready to meet it. If you found this interesting, Check out this video on the screen now. Comment below if you are going to be simulating a hantavirus outbreak with your teams.